GLP-1. It's been many years since a drug abbreviation created so much buzz. Ozempic, Wegovy, Mounjaro are becoming household names globally, and I'm sure that will percolate into India. For people that don't have context, this is a new class of diabetes management and now weight loss medication that mimics the effects of a naturally occurring hormone called glucagon-like peptide 1. The annual revenue for the drug class this year is $35 billion, and the drug class is estimated to exceed well in excess of $100 to $150 billion by 2030. Drugs are flying off the shelves. They are not available. Trials have shown benefits in other disease areas like reduction in cardiovascular disease and also slowing down the progression of chronic kidney disease. Is this a fad? Is this a reality? In which case it would be the biggest disruptor the healthcare industry or the drug industry has seen in a long time. In fact, I don't remember drug classes creating so much buzz even when it was the statin class that was launched for cholesterol management or even the launch of Viagra. But of course, that was in an age without any social media. So we've got some very interesting panelists to share their perspectives. We have the drug manufacturer, we have the physician, a renowned endocrinologist, and also Dr. Joshi, our first Padma Shri at Scale Up Health. So welcome. We have the consumer. Madan will represent the consumer. He runs a very successful digital health startup focused on diabetes and weight management that is direct to consumer. And then, Carl, we are going to have you represent a geography, if that's okay. The US. Carl, of course, as Dia introduced him, is both a digital health entrepreneur and now an investor. So with that, Vikrant, your phone number is more prized than a Bollywood celebrity right now. But the truth is Vikrant does not have access to the drug either. He's also in a very enviable position, as Dr. Joshi mentioned, where he has no sales targets. Because whatever target he sets for himself, he will exceed. And right now, he has no drug. I wish many of our entrepreneurs had this situation. So maybe Vikrant, for the audience, set some context. What is this new class? How does it work? What are its effects?
Thank you very much, Prem. I think this meeting is a scale up, and I believe you can't scale up health without obesity. I thought there was a disruption with the COVID in 2020 in the March. And I think so there was another disruption in healthcare market that was anti-obesity treatment. We also never imagined, to be honest, that we could have this kind of a celebrity status coming out with medicine. We thought we are a small little organization somewhere in Denmark, 5 million population.
As your market cap is more than the GDP of Denmark.
Absolutely. So we thought, we are a protein powerhouse. So we started insulin a century ago and came out with different variants of insulin, which is protein. And likewise, some factors and growth hormone. In the journey, we came out with another solution, GLP-1 for diabetes. And then we saw this profound effect on obesity. We were really scared with what has happened to other anti-obesity drugs. I also had the honor to launch the another anti-obesity drug with Abbott, the Reductin, at that point of a time, some 20 years back. And then we were so scared, we thought probably, it could just be a dream that there is a solution. But just so happened that when we saw the result to a 15% reduction of obesity, that became quite a landmark in terms of the treatment. And if there are no treatment, there is no advocacy for the disease. Many of the people in the room, in fact, 30% of the population has got obesity as a problem. And we saw
Got one sitting right here. So
Dr. Shashank say that, he started the anti-obesity practice a decade ago. He says, patients see me and then they run away and then they become slim, So we saw this profound effect, this drug, with 15%, and many other solutions are going to come with 20%, 25%. So this is probably a drug where you can really scale up the treatment for obesity. And obesity, which is so common, but it is never seen as uncommon. And something which is seen in everyday life with every second person becomes acceptable in terms of overall behavior and overall society. So when we came out with this drug, we thought, okay, find one more solution. We always think that we are coming out with a fantastic solution and probably this is the market size. But with every month, every quarter, let me tell you, the size of the drug and the market kept on increasing. In fact, you just now enumerated 150 million, which is 150 billion, and with every conference, every meeting where we go, it just multiplies by 25 billion. So this is, how does it work? It works, basically it is biologic and it is human hormone in the gut. It delays the gastric emptying and it does some work in hypothalamus in terms of bringing the satiety feeling. But what is wonderful about this drug is that apart from the diabetes treatment, obesity reduction, the other cardiometabolic effects which are coming, you can see the entire renal benefits which are coming, Alzheimer's, where we are in the phase 3 trial, actually MASH, the area of NASH, where also we are in the phase 3 trial. I think when you see these multitude of the benefit, no wonder that a pharmaceutical company can actually reduce the stock of Coke, or the Walmart cloth sizes can get reduced, or even the dialysis stock get, to the half when the results come.
And I'll come back to this, Vikrant, because I do want to talk about the benefits. But let's hopefully have some provocation here. So we will move to the physician. And Dr. Joshi, does the drug work? Is it hype? Is it reality? But most importantly, is it safe? I think that's the question that at least I hear when I speak with colleagues and other people in the industry.
Thanks for having me here. I think you want to start with the provocation. The drug definitely works, and if jerks like Elon Musk and Kim Kardashian endorse it, okay, and I know what I'm saying, okay, it definitely works. Is it safe? Currently, as per the US regulation, Europe regulation, it appears to be apparently safe. Unfortunately, he mentioned Reductal, which he should not have mentioned. The dubious distinction of obesity drugs over the last 5 decades is every drug which comes in after 5, 10 or 15 years gets banned because of a sinister side effect. Mayo Clinic notoriously reported on fenfluramine some carcinoid-like lesions. Reductal went away because of a cardiovascular outcome, which was another drug called Rimonabant caused suicide. So, but I personally feel that these drugs are clearly disruptive because they switch off the appetite, okay? And they were discovered by accident, just like sulfonylureas were discovered in the World War because sulfonylureas caused hypoglycemia to the World War soldiers. These drugs used to cause vomiting and popularly were called vomiglutides. And then there were scientists in Germany and Denmark who actually dosed them in a particular way. And these low dose slowly going up, they were able to get the benefits for weight loss, beyond diabetes, beyond heart disease, kidney protection, liver. So now we have all organs being protected and the data is so compelling. And all these are FDA regulated trials that it appears currently that there is rare safety issues currently, and at least we have a decade of safety registries on some of these molecules. The challenge is that in the Indian population, we are thin fat Indians, Vikrant was saying that I started my obesity clinic almost 3 decades back. That time there was only lifestyle. Nothing else was available. There were more quacks in the market. They had their own lifestyle clinics and they were able to lose weight by paying money. If you want to lose weight, the easiest way is, you can just ask some money and then tell them to do whatever they want, they will pay. So it was all a behavioral marketing strategy. Then the drugs were only a pharmacotherapeutic adjunct. Then the surgeons came in and the endoscopists came in and they took away the market. They are completely threatened. They should change. Like just the cardiovascular surgeons have become extinct after statins. Clearly, the bariatric surgery industry is threatened. Food industry is threatened. Okay, economics is threatened because obesity is a mother of 200 underlying diseases. Mental health, physical health, liver, heart, kidney, he said about brain, and many more other diseases. So I think clearly these drugs work for sure. And it's not just switching off appetite. That is, there are single agent, dual agent, triple agents. So the single agent is working on this gut peptide, which switches off the appetite. Causes a little bit of nausea. You need to start with the lowest dose, be a little patient. In 3 months, you will get benefit. The dual agent is much more compelling and you will get a little more weight loss. And the triple agent will put the bariatric surgeon out of practice. But the single agent in India, whatever Vikrant was able to produce, and half the time, we are good friends now because I'm yelling at him, 7 milligram is not available. Then he has to smuggle it for some of our patients. 14 milligram is not available. Half the time he doesn't have stocks. So, that is the challenge. They are disruptors. And they can cause disease remission. See, the other thing is, if you get 15% weight loss, you will cause remission of diabetes. You will cause remission of liver disease like MASH, which is called now, and many other diseases. And it can protect the kidneys. Of course, transplant industry is under threat. But this is long term. The current challenge is, I think, they are here to stay. They are currently looking safe. I don't see any, it's more, internet-mediated smoke around some gastric paralysis and suicides, which looks to be very unlikely. Okay, some thyroid nodule, calcitonin issues, again, which looks very unlikely. We have been very pharmacovigilant. Every drug which works will have some adverse events, but currently, everything apparently looks to be safe, and they clearly are effective. And in the Indian population, they are much more effective because we store more fat. Ancestrally, we are born to store more fat. So I think the data is very compelling even in the Indian population. And I think the safety throughput is pretty reasonable and robust.
Very helpful. And I'll come back to you, Dr. Joshi. Madan, you run a very interesting digital health startup, help patients manage diabetes, weight reduction, and so far you've been doing it without the drug. Is the drug going to disrupt the business?
No, good question. A lot of
and give us some perspective on how you are seeing some of this excitement play out.
No, I think for us it's very exciting as well. At the end of the day, we are a consumer business. I think our whole idea is, can we create a platform, solutions that can help people see very strong outcomes, right? And I think like Dr. Shashank said, clearly there is compelling evidence to GLP semaglutides. For us, we actually see ourselves over the medium to longer term, one of the largest distributor of this. Today, I think we would be one of the largest probably in terms of diabetes management players across the country. We do have already today significant number of users actually asking about this, right? So for us, I think it's very positive, right? Anything that helps a user use the right way. The benefit we have probably is the amount. I think during the previous panel, they talked about repeated user behavior, repeat rate, right? For us, the benefit is we have coaches, doctors talking to the patients every day. The results can probably accelerate, right? I think there is no doubt in India. I think consumer psyche is very interesting. Everyone wants a magic pill. Everyone wants instant gratification. If there is a solution that helps that, absolutely people will bite. I think what will be interesting and what we hear in India specifically is a couple of elements around the form factor, right? And around kind of acceptability over longer term, right? I have no doubt. I think we today in India as a consumer company or even globally, I think the world has changed, right? I think the positive viral effect plays a very strong role coming from the US. Like he said, a lot of celebrities kind of using it. Over the long term, I think if efficacy continues, that will just skyrocket and it'll be a huge boon. But like Dr. Shashank said, health is at probably in India specifically, India is generally a trust deficit society, probably more so in health, right? As long as there's no negative reaction to any of this over the long term, negative viral effects can also equally spread quickly, right? So I think as long as used right, I think all evidence today shows very positive kind of impact for this. I think it will be a very strong use case for consumers. But I think it's interesting, a lot of users in India, given the price point factor, form factor, those are probably you cannot compare apples to apples versus the US. I think a health in US, health in India is very different. And those are the elements we'll have to see. I think the Indian consumer is also much more wary about having something externally go into the body for something that is not life-threatening. I don't think many people see today obesity as or diabetes as very life-threatening. I think one of the things we contend with as a platform is how do we increase sense of urgency to help people take action earlier, right? We've seen anything externally needs much more education, much more convincing to the consumer, which obviously as a platform like us it's good to have all this. But I think those are the interesting elements that will play, right? I think just the word out there right now, I think there'll always be early adopters in this. There is no doubt. I think the question will be over the long term or medium term for a broader set of consumers.
And that's interesting, Madan, because amongst the digital health startups that we have seen, you've had an excellent retention rate within your customers. So you do a very good job, even in the absence of the drug, making sure people stick to your program. You've got coaches, and you manage that really well. When you think about the first, and of course from personal experience, right? The first time you say, look, I want to lose weight, and you sign on to a platform like yours, right? You change diet, you begin to exercise, and the first 3 months look fantastic, right? You've lost some weight, you feel better, but then time passes by and you put the pounds back on, and then in sort of cycle 2, it becomes harder to do that. So do you see the drug becoming a part of your routine regimen as you design programs for patients going forward? Assuming Vikrant is able to provide access to the drug for everyone. But
no, absolutely. I think obviously there's a specific cohort of users, right? I think the beauty of us is just the depth of data we have, given the type of users we're able to classify what type and the quantum of users. I 100% see a view even in the short term where these will play very important roles in our program, right? Absolutely, right? I think as a company you build, you have to give consumers what they want in the right form, right way, right price, right? That is key. I think fortunately for us, we'll have a fairly premium set of consumers given our price point. So 100% it will be in the regimen. Is it, you're right, one stage solution for all? Probably not. But this first element you said is very interesting. I think in most platforms you say it's human nature. Today in a gym, if you go to first 1 month, very attached to it. After second, third, fourth month, it drops. I think similarly, what is interesting with this drug also is the need for repeated usage, right? So it's not, I think that's where platforms like us, and for a user, they will need all, right? It's not like you use it for 12 months, you're free of kind of obesity. There is a strong likelihood it could come back if you fall to habits. So those are the interesting elements that will play where platforms become very important as well.
Carl, the US has had some more data points. The drug has been in the market for a bit. Tell us a bit about, we of course heard from the manufacturer, the physician, and those translate globally. How is the US consumer reacting to the drug? Talk a little bit about how the stakeholders in the ecosystem are feeling about the drug.
Well, first of all, thank you for letting me represent a whole country. It's been my dream to be an ambassador someday, so here I am. I think whenever there's something that's this exciting and it comes on so quickly, you end up with sort of two camps, the maximalists and the skeptics. We saw this with Bitcoin, for example. The Bitcoin maximalists, the Bitcoin skeptics. We were just hearing on the other panel about liquid biopsies. Maybe it's 150 billion, maybe not. We'll see. I think with this innovation, it's very easy to be a maximalist. And you say, wait a second, 1 billion people, adults, will have obesity by 2030, 250 million children by 2030 obese, a $2 trillion global burden of obesity. And now you have a silver bullet. This drug comes along. The diseases it relates to relate to a third of deaths per year. So this is a massive opportunity. But on the skeptical side, it's sort of the reality test. And I just yesterday spoke with the CEO of a Medicare Advantage plan, and I would put him in the skeptic category. He pointed out that in the data he has, only 27% of the people who start the drug are still on the drug 12 months later. And then they put the weight back on, as you said. So the area under the curve is not a lifetime at healthy weight. It, for some people, is a short period of time. The other skeptical point is the cost. Today it's, no one knows if it'll land at $500 a month or $1,500 a month. But that's the other concern, is that you're weighing the cost versus the benefit. And if the benefit's going to be more short-lived, it speaks to some of the points about acceptance. If it's a pill, if people have the slow dosage that it was just mentioned, well, then maybe you'll ameliorate a lot of those side effects that are causing people to come off the drug. So, and the last point on the skeptical side is that the payers in the U.S. have tools at their disposal to slow the roll, if you will, of people coming onto the drug. There's cost sharing with the patient. If patients are paying 20% of that cost, that could be a significant barrier for a lot of people. You also have pre-authorization, step therapy, other tools. And then we have a whole industry in the U.S. called the pharmacy benefit managers, where we've taken the drug part of healthcare and made it a separate product with a separate company that manages its utilization. It strikes me as challenging when the return on investment is such that the investment is done by one company and the return on lower healthcare costs happens in a different part of the company. So these are reasons to be skeptical. But one thing that did stick with me, the reason I actually, despite telling you the skeptical points, would put my lot with the maximalists, is that there's such a big potential impact for society when we get this right. The CEO of one of the companies that's not yet in market in this space said, for most countries, the health minister goes to the finance minister to say, can you please pay for something? And the finance minister says no. This could be the case where the finance minister is going to the health minister and saying, we need to do this because the benefits financially in the long run could be that great. And so that's what I'm excited about. But the realities in the industry are that many aspects of how this would need to be financed and delivered are complex and will take time to work out.
And the distinction or a big distinction between the US and the India market dynamic is that the US is largely an insured market, unlike India where outpatient is out of pocket. Talk a little bit, Carl, about how is, at the end of the day, it all rolls up to the government. And then you say, look, are you willing to foot $150 billion bill over and above, the several billion that you spend on healthcare? What are some of the various points of view that you're hearing about from the insurers, from the government? How are they grappling with this? Because it's, of course, an opportunity, but in the short term, somebody has to pay the cost.
It's a very good dimension to look at, because in the U.S., we actually have all of the healthcare systems in one place. So if you're a veteran, it's government-delivered healthcare, completely. If you're old, it's Medicare, which means private delivery, public finance. If you're poor, it's similar, but the benefits are worse. Everyone in the middle, you have to go get insurance from your employer, and usually in those cases, the employer is actually paying the full bill. So the insurance company is acting as an intermediary, just passing on those costs. When you add it up, if the healthcare industry costs go up 10% in a given year, almost everybody in the U.S. wins. The doctors have more funds. The administrators have more money to play with. The pharma companies make more money. Everybody wins, except, as you pointed out, who's going to pay for it all? And that bill is usually put to the government for Medicare and Medicaid, and it's put to employers for those in the middle. And they then share those costs with the patient more and more to try to help with that burden. We're in the middle of a presidential election. I don't think either candidate is spending any time really talking about deficit reduction. And so in general, I think the solution is just print more treasury bills to pay for all this stuff. Now, this may be a case where there's actually a positive return on investment if we can reduce the very significant costs of these diseases. But it's a complex system. It's an expensive system. Part of the reason is it's expensive is we have this complexity, many different layers on top of layers of different ways to be reimbursed, to access treatment. And I should also point out many people who don't access treatment because they can't navigate the system. So many problems, but in general, the bill falls on the employer or the government.
Understood. Dr. Joshi, I'll come back to you. Typically, and maybe this is me, I'm the trusting patient, but I go to a doctor when I'm not well. The doctor writes a pill. Increasingly now I look it up online before I buy it, but then I buy it and I consume it. Are you seeing patients coming and asking you for the drug for the first time? What are you seeing being different about this drug in terms of your own clinical practice?
Oh, absolutely. I think, I practice in, both sides of the bridge in Bombay. And the Sobo side of the bridge as well as the Banta side of the bridge. And people, have people all over.
Which side do you like more?
I'm not so sure of that, because people are getting this drug from across the world. They are just coming to me because they just want to know how to take it properly. And if there's an adverse event, how to handle it. But you will not believe it.
So they are coming to you with the drug.
They are not just knowing that they are coming to me to ask for the drug. They are coming with smuggled packets of a Mounjaro or of a Wegovy or of a Ozempic from Dubai, from London, from United States, navigating the system. Because in the previous panel, somebody said that we have the Emiratis of the world who can afford all of us and probably everybody in the room, which type of people we see in Mumbai city, and they are from all over India. So this drug is explosive. But even a middle class or a new rich person who is very internet savvy, and of course we have now 2 universities, Google University and WhatsApp University, which is extremely active. Okay, people actually come and ask me, even people who are my regular clients for maybe, 20, 30 years, they say, look, this is a wonder drug. It will make me go away from my insulin. It will take care of my liver. My heart disease will go away. I won't need a bypass surgery. They actually come and ask you.
And it's not cheap, right? It was 45 to 60,000 rupees per injection.
So I think the unofficial off-label cost of this drug, injectably imported, is anywhere for Vikrant's product is around 20K a month. And for the dual drug is around 60K a month, which is pretty expensive. It's almost 3-4 times the cost of its, because there are different price points of different launches across. People are managing to get it because they're desperate for losing weight, for the benefits which are compelling, which are happening. But I'll tell you one small story, and I think my colleague here alluded to it. See, weight loss originally has been an attractive market in the cosmetic space. Okay. And that is the space where people want to fit the bill for maybe a marriage function, for a party, etc. So people don't see obesity as a disease. What I have seen in the last 3 decades is when I started my obesity clinics 3 decades back, most people came to me around the wedding season. Now that transformation has happened And people are coming to me because they don't want to go and spend for complications. So I think the reversal, remission, and complication free from a disease, the awareness has gone up. And I think that's the big game changer. So I think clearly people ask for it. People have read about it. They know all the, unknown side effects of the drug. Okay, they read something on the internet before even it reaches me. For example, somebody said, doc, this drug can cause eye stroke. So this was the first time I was hearing the term eye stroke. So, before that, I knew that there is a JAMA, analysis from Harvard, which had come with some eye stroke related to semaglutide. I said, this is very anecdotal. And the cause-effect relationship is not known. But the patient is saying, so, even before they consume, they want to know all this Googling. And that is, remember, Google and WhatsApp are the most hazardous digital tools we have. They promote sedentary habit. They clutter our brain. They are not peer-reviewed. And they are, lot of crap in it. So I think we need to be very, we are the sorters for that. So I think there is a need, there is a demand, and there is a lot of information already floating out there. And we need to educate and actually give it to the people who are most deserving. Does everybody need it? Probably yes. Should we segregate? Probably yes. And in the US, Europe, Middle East, where it is available, it is all about segregation, it's all about rationing. And then we are putting some yardsticks to it. But I think it's a general need and it's a scale of cost and availability.
Got it. Madan, what are you saying? You're direct to consumer, are the consumers demanding it? And I know Vikrant hasn't given you his phone number, but
no, absolutely.
How are they getting the drug?
I think what Dr. Shashank said is absolutely true. We see the same in significant order of magnitude. Obviously, Indian people are resourceful. They'll get their hands on something they want. So we've seen that, and the same thing. They come to our doctors, coaches to say, how do I use it? Is it effective? Is there any kind of side effect that I'll suffer from, and how do I mitigate it? But surprisingly, what I would say, given the volume of users we see, we expected probably a larger chunk, and probably that comes back to price point and what people can afford, right? We have decently different classes, but I think he's spot on. We've seen this ask more in the age group of around 32 to 38 and less so post 40, which is interesting. I think probably that age group is kind of people who are more kind of aware. They, say fitness is the new fashion. They kind of want more cosmetic stuff. So I think we've seen those age groups. How it plays out as it goes will be interesting. But demand and kind of inbound request has been quite significant.
Fascinating. Maybe, Vikrant, let's step back a bit. Of course, India will be a big market for weight loss medication. I think it's a matter of time. But how else can India participate in this global surge of anti-obesity medications, just given India's inherent strengths around services, manufacturing, research? Is there a way you can see India being able to cater to the world's demand in other ways beyond being a market?
Yeah, as a pharmaceutical company, I think the prime responsibility is, of course, to offer the medication, which I don't have right now. But, whenever it is available, of course, it should be there for the population. So that's the prime responsibility. But when we do the business, we also try to see how to really bring more value in the country and also do much more than just having a commercial transaction. So I should say that one of the angles where Novo Nordisk took the lead is the GCC, Global Competency Centers. And just a simple quiz, if you think that the pharmaceutical market or pharmaceutical employment is actually in Mumbai or in Ahmedabad, I can tell you that more number of professionals are employed in Bangalore because we have 5,000 people. Lilly has got 5,000 people. Glaxo has got 6,000 people. Takeda is there. Teva is there. So it is becoming a global competency center. When I say global competency center, so they participate in the drug development. There are 300 data scientists who are actually working in the drug development, just taking the published data and simulating what is the next drug going to be in obesity treatment, which can actually potentially bring 25% reduction. The second area, which is actually there and which is also very important, is the clinical research part of it. And we say, Jai Vigyan, Jai Anusandhan, the Modi, the credo which is going, innovate in India. And I think we are leading that path as a pharmaceutical company, and many other companies have also started to participate in the clinical trials so that India is part and parcel of that innovation of the drug. So even for semaglutide, I don't think so there is any trial, whether it is in diabetes or in obesity, where India has not been party to it, including the renal trials or cardiometabolic trials, which we have done. So that's another area. The third area is, of course, the manufacturing part of it, but I'm sure that these are all biologics. So we never thought that we could invest to the tune of 24 billion in terms of getting the active ingredient and, filling and shipping. So 24 billion has been invested in Denmark, Kalundborg, as well as in the US put together just to come out with the drug requirement to the world. So when we see it in India, I personally don't think so there is a scope in terms of getting the active ingredients, but we can't say no ever. I think we have got manufacturing of insulin in India, and that is there for torrent long, almost for 3 decades. So maybe when there is a fill and finish kind of a requirement, there can be some kind of a potential which can also come. So it's in the entire value chain. I think it's not only this drug, which is also a...
What about just post-market surveillance and services around that? The other interesting thing, which I think is also relevant for companies like SugarFit and Madan's, is Lilly recently announced that they are getting into the services sector where they'll provide the drug, they'll provide the physician, they will provide associated services. So very much like SugarFit Madan in the US. Do you see some of that being able to be managed out of India for the world?
I think so. And there are good players who have come in that ecosystem with the disruption with the medical, the anti-obesity, GLP-1. I also see quite a lot of digital player, and they are making very big difference in terms of overall treatment which is actually being given, and handholding the patient for the treatment adherence, because the biggest drawback is that people are looking for how much time I have to take. And it's the same thing which I say, that for how much time you have to do the exercise, you have to do probably till the time you live. And you have to eat also till the time you live. So it is a metabolic disorder. And now it is actually labeled as a disease per se, by American Medical Association, Canada Medical Association, in fact by WHO, as a disease and disorder, as independent. You can see diabetes and cardiometabolic, diabetes and brain, obesity and brain, obesity and diabetes, obesity and arthritis, obesity with infertility. But obesity itself is now labeled as a disease. So I see a big part of the ecosystem for the disease and the treatment with these digital disruptions. And I think so it is going to be put together, which can make the difference in the society.
And just building on that, Carl, and I think Dr. Joshi also alluded to this earlier on, what other disease segments do you see being disrupted in the US with this drug?
It's a good question. I mean, I think the theme of the last panel and this panel is sort of going upstream on the disease to get a control of the root causes, such as a liquid biopsy to detect cancer early, or to address obesity so that you don't then have the follow-on effects. I mean, the patient who came saying they want to get on this drug because it'll help me with my heart problem, unfortunately, tragically, a lot of those problems, once they've developed, are not going to be greatly helped by this drug. But if you address the obesity early, those problems may not have developed in the first place. So I think, if you look at the big sources of years life lost, oncology and metabolic disease cover most of them, actually. So I think this is kind of the key drug. By the way, I wanted just to note that it was mentioned that my fellow panelists don't have access to the drug yet they all look pretty slim, I think. So I'm wondering about that.
I think we could go on and on. This is such an exciting topic, but we're running out of time. I want to keep a question or two for the audience, but I have a last quick fire question for all of you, and maybe we'll just go one by one. Do you see in 5 years this becoming a pill that you pop every day like a multivitamin, just given all the health benefits?
Ideally, it depends upon the regulator, but
I think your only answer is yes, because then you don't have sales targets forever, Vikram.
I can actually say that this is one disorder, unlike oncology. You see it in the mirror and you know that you have a problem, right? So there can be potentially a day, based on the regulators, how they treat it, that potentially it will have some kind of a space. Of course, time will only tell if there are side effects, any kind of things which, untowards action which can happen.
Dr. Joshi, what do you think?
I'm a lifestyle proponent, but I still feel this pill is a easy excuse for lifestyle. And anytime you get an excuse pill, it will stay in the market as long as it is safe. So it's clearly here to stay because of most of us, and he asked us why we are all fit people, we are all marathoners. Okay, and I was an athlete.
Except me,
I'm
Carl.
sure he was, and so does. So we still are the lifestyle proponents. We may be writing this medication, but we strongly believe in lifestyle. But people don't like to do that. People are sitting here for the last 2 hours, which means they have smoked at least 4 cigarettes. Sitting is the next smoking. So all of you all have congratulations to you for smoking 4 cigarettes. Okay, so it's important to recognize that they'll still smoke and still keep sitting. They will not get up, except maybe Sudarshan who went out. Okay, so it's important that these drugs are here to stay because they're excuse pills.
Yeah. Madan?
Just I echo what he says. I think big lifestyle proponent, but people love magic pills. I think in the right form factor, right price, I think it'll be lapped up. But I think 5 years, if you say 5-year time frame, a lot of questions still. But every human wants a magic pill. So if you're able to get that, probably.
Carl?
If we all ran marathons, we wouldn't have this problem. So that's a very good point. I think what's interesting in this case is there are actually many companies with products coming to market. Lilly and Novo have led the charge and are getting the benefits of that. But there's a lot in the clinic that's distinct. And so I have a feeling that means you're going to have many different types of product for different price points and different needs. And so that some people will be popping pills, as you said, or other people will be maybe getting a monthly injection. Some of the new therapies that are being investigated have much longer half-lives than the initial drugs. And it'll probably be a lot of combination therapies as well. So with that type of diversity of IP, I think some of those companies are going to be fighting to get approval from health ministers or from pharmacy benefit managers, and they'll do whatever it takes, being resourceful, to get their product to market.
I think the one, and we don't have time for it, but the one question which is a controversial one, and therefore I won't ask that question of any of you, is also whether in the short term the government pushes for a generic version if the benefits begin to... Dr. Joshi, you want to take that one?
I want to take that because I think they should. Vikrant may not like me.
Of course he doesn't, but...
Okay, but I think we should because obesity bankrupts economies. And if you want to have a game changer, they should do a license. And there are enough Indian manufacturers we can do that. And I think we can have a solution for the world because we are the pharmacy of the world. So if we don't manufacture it, who else will? So we can give them a solution within India. And it's a global emergency. Obesity is a global emergency. As he's saying, if the finance minister has to go to health minister and you have a solution, why not do it?
Yeah, it's very much like, I think somebody raised the point around Hep C, where we have Dr. Satya, who was the first generic for sofosbuvir, more or less cured the disease in the country. But look, unfortunately, we are out of time. I can't offer questions to the audience, but we will step out for a short tea break and you can catch them there. It's been a fascinating panel. I think that the story has only begun to play out. So watch this space. But I'd love for all of us to thank our panelists. Thank you for being here today.